Thanks. It's a pleasure to be here with all of you this afternoon. You've heard about many of the concepts of immunotherapy, which hold true for melanoma, and as we're finding out recently, for several other kinds of cancers, at least, as well. So I think that you all realize the issue with melanoma, which is that it is one of the cancers that is in the most rapid rate of rise of any cancer in the United States. So in 2014, we expect about 76,000 new cases of melanoma in the U.S. and nearly 10,000 deaths from this disease. It is one of the most common cancers in young adults. The 5-year survival is much better than it was 10 or 20 years ago, but it is still not breaking 15% across the board, even with all of the new promising drugs that have come into the clinic recently. And so we know that we still have a lot of work to do in advancing therapy for melanoma, and especially for patients with stage 4 disease. Now, many years ago, we had the first hint that melanoma would respond to immunotherapy. And what I'm showing you here is a chest X-ray of a patient with melanoma who was treated in 1987 at the National Cancer Institute when I was working there. And we found that simply directing a drug against the immune system, because that's what IL-2 does. It purely has an immunological mode of action. It does not directly attack cancer cells. But simply with this maneuver, we could cause the regression of very advanced melanomas. And this could occur quickly, as I'm showing you here in this slide. So we saw durable melanoma regressions in about 16% of all the patients that we treated. And this was extremely encouraging. On the other hand, this is a treatment that needs to be given in the hospital, and the associated side effects have limited the use of this treatment. Most recently, as you heard in the previous sessions, with sequencing of the DNA of cancers, we've realized that melanoma has one of the highest mutational burdens or mutation rates of any human cancers. And while this has created challenges for using targeted therapies against melanoma, and by this I mean drugs like BRAF inhibitors and MEK inhibitors, it actually creates opportunities for immunotherapy because, as you heard previously at this meeting, these mutations can create new proteins that have never been seen before by the immune system, and they can be very powerful stimulants for anti-tumor immune responses. So these mutations, while they are very numerous and very diverse, can create a common denominator for immunotherapy. In many ways, the immune system is an ideal anti-melanoma agent. And you heard about this this morning from Dr. Pardol, that the immune system has properties that we want to engage in anti-melanoma therapy. It's very diverse, and so the T cells and B cells in your immune system can recognize an almost limitless number of different entities. And in the case of a highly mutated tumor like melanoma, this diversity is good because it means that the immune system has the opportunity to attack melanoma from many different perspectives. The immune system is highly specific, meaning that if we use it properly, it should attack tumor cells and not spill over into normal cell inflammation. And the memory component of the immune system means that the effect can continue to percolate even after we stop giving the drug that we're using to tweak anti-tumor immunity. So despite all of this, what we have found is that the natural balance between melanoma and the immune system is something that we call tolerance rather than rejection. So the immune system and the body tolerate the presence of melanoma. We often observed that we could look at melanomas under the microscope, and I'm showing you an example here where we would see sheets of tumor cells, which are the larger cells, but we would also see these sheets of infiltrating immune cells, which are the small round purple cells. And so the tumor and the immune system is coexisting. These immune cells are not capable of destroying the tumor cell, and the question is why. So as a result of a lot of hard work in the laboratory by many groups over the past 15 to 20 years, we realized that the natural balance between the immune system and melanoma is this tolerance situation, and we actually could define what the different tolerance mechanisms are. And it's only by defining these that we can then work out solutions. We can design therapies to disrupt these tolerance mechanisms, and the objective then is to rejuvenate immune responses against melanoma in a way that the immune system can destroy melanoma. So I'm showing you here three broad categories of tolerance, including on the left regulatory immune cells. So there are cells called Tregs and other cells called MDSCs, whose function it is to dampen immunity. In the middle there we have immune suppressive cytokines, and you heard a bit about these. There can be cytokines that make the immune system more aggressive, such as IL-2, but there are other cytokines that can suppress the immune system, such as IL-6 and IL-10. And then we have these T-cell inhibitory receptors, what we call checkpoints, that are displayed on activated T-cells. This is part of normal immune biology. The normal function of all of these mechanisms is to turn off immune responses at the right time so that they don't continue on indefinitely and destroy normal tissues. Every immune response has a job to do. It's directed against a specific target, like a virus or a bacterium or a tumor cell. Once the target is eliminated, the immune system is supposed to turn off that response. But what you've seen in the previous talks this morning is that tumors can co-opt some of these normal protective mechanisms to escape immune elimination. And so our job is to rejuvenate these responses. So I'm going to very briefly today talk about three different approaches to overcoming immune tolerance. So on the left there, you see in order to overcome some of these regulatory immune cells or cytokines, we can use melanoma vaccines. We can also take immune cells out of the body and manipulate them in the laboratory and then infuse them back into the patient, and that's called adoptive cell transfer, or ACT. And then on the right side, for these immune checkpoints, we can develop drugs that block the checkpoints and so reactivate anti-melanoma immunity. Now, melanoma vaccines have been in the clinic for over 20 years, and there are many varieties of these vaccines. Some are designed to activate immune responses against what we call shared melanoma antigens. These are proteins that are expressed in most melanoma patients. They are not mutated proteins, and for that reason, they're actually weak stimulus. Thank you. Yeah, okay. But you may recognize the names of some of these vaccines. They're vaccines against molecules like GP100 or MAGE-A3, and they've been in the form of peptides or proteins or even viruses that have been engineered in the laboratory. You heard a little bit about that this morning, to express melanoma proteins. These types of vaccines were not very successful in many clinical trials in which they were tested when they were used as single agents, when they were used by themselves. And then we have other kinds of vaccines which are designed to incorporate these mutated molecules that we find in melanoma cells. Some of them are composed of viruses, inactivated viruses that are locally injected into sites of melanoma. There is also the possibility that irradiating individual spots of melanoma can act in a way as a vaccine that can then have a spillover effect to other sites of melanoma in the same patient. I think Dr. Walchuk is going to talk a little bit about this in this session. And so there are many ways ways to kill tumor cells which by themselves might not be effective enough, but they create disruption of tumor cells in a way that can jolt immune responses. And then if you combine these with drugs like anti-CTLA-4 or anti-PD-1, that combination can be very powerful. So even though vaccines by themselves have not been that effective, I think vaccines may have a renaissance in the next few years now in combination with the checkpoint blocking drugs that you're hearing about today. As for adoptive cell transfer, this is a very broad landscape. There are many varieties of ACT. I'm showing here some of the different kinds of ACT that have been used in clinical trials in melanoma, ranging from tumor-infiltrating lymphocytes, which are grown in bulk from surgically removed melanoma lesions, all the way to individual T-cell clones, which are highly specialized and need to be grown under very special conditions in the laboratory and are very difficult to generate. So it turns out, after many years of research, that actually the highest response rates that we saw in patients with melanoma were with these more diverse populations of T cells before we started trying to fine-tune and manipulate them. And it may be because some of these T cells are seeing different mutated antigens in the melanoma, as well as some of those shared antigens that I mentioned earlier. One approach that uses genetic engineering is called chimeric antigen receptors. These are molecules that can be introduced into the laboratory into immune cells that are circulating in the blood, and they can endow a T cell with new targeting properties. And so this really is a merger of T cell activation properties with the specificity of an antibody. And you heard about antibodies this morning. There are many ways that these can be constructed or engineered in the laboratory, and there's a lot of science that goes behind this to make the ideal receptor that is powerful enough but not too powerful, because if they're too powerful, again, you start having too much destruction of other tissues that besides the tumor. Certain CARs have been effective in patients with adult and childhood leukemias. They are under development now for treating melanoma. It's not clear whether this is going to be an advantage in melanoma immunotherapy or for other solid tumors. I think the trials in the next few years will tell us. And so for the rest of the time, I'd like to talk about immune checkpoints and the drugs that we use to block them. As you've heard already today, the immune system is in a state of balance between what we call tolerance, where the brakes are on the immune system, versus surveillance, where the brakes are off and the immune system is aggressively seeking out targets. And ipilimumab, or Yervoy, was the first drug directed against an immune checkpoint that was approved by the FDA. It was approved because it improved the overall survival of the melanoma patients in this phase 3 trial who received that drug compared to the patients who received a peptide vaccine. And you've heard this morning about the tail on this curve, and so these are very durable, long-lasting tumor regressions going on in some patients now for many years. You've also heard about the immune-related side effects that can occur with this form of therapy, which require early recognition and special management. In terms of PD-1, this is a checkpoint in the same family as CTLA-4, but it has a very unique role, and as Drew Pardall told you this morning, there are a few dozen of these different checkpoints, and they all have unique chemical structures and unique roles in the immune system, depending on where they are expressed in the body, at what time during the immune response are these the most important. So in the case of PD-1, by understanding how this pathway works, we can understand how to improve the drugs that we are using right now to block this pathway. T cells are very important cells in anti-tumor immunity, and they function according to two different signals. And so the first signal is a recognition signal where they actually recognize the melanoma. But the second signal is a modulating signal, which can either activate or inhibit the T cell. So in the case of a modulator like this molecule CD28, the T cell then becomes activated, and what that means is that it begins to proliferate, it can secrete cytokines, it acquires killing activity against melanoma, and these cells can percolate throughout the body. They migrate to sites of tumor to seek out where is the target and to destroy the target. But at the same time that that's happening, they start to express these turn-off molecules like PD-1, and again, the normal function of these molecules is to terminate immunity at the appropriate time after the job is done. What happens is when these T cells migrate into sites of tumor, if the tumor is expressing the partner molecule PD-L1, when PD-1 interacts with PD-L1, those T cells are turned off. And so by blocking that interaction, either by blocking PD-1 on the T cells or PD-L1 on the tumor cells, at least theoretically, we should be able to turn those immune responses back on in a way that the immune system could then destroy the tumor. And so in our experience with nivolumab anti-PD-1, what we saw were responses in approximately 30% of patients with advanced melanomas that had not responded to other kinds of treatments in the past. And so this is showing you an example of one such patient from Johns Hopkins who had about half a dozen tumors like this. This is a tumor in his groin area, and you can see after the treatment that this tumor is gone, and also all of the other tumors in this patient's body totally regressed. And so now it's over 4 years since this gentleman started his therapy, and he is still cancer-free. Now, at the same time that this anti-tumor immunity was occurring, he also developed this patchy blanching of his skin, which is called vitiligo. And that occurs when normal pigmented skin cells are destroyed by the immune system. And so we see this as a cross-reactive side effect of anti-tumor immunity that's directed against normal components in melanoma cells like GP100, which I mentioned earlier. This can also destroy normal pigment cells, and we saw this on skin biopsies. So this is an example where an immune-related side effect was associated with a very powerful anti-tumor effect. This is another patient that we treated, a 35-year-old fellow who came to us with a very aggressive melanoma on his face. You can see it here on this MRI scan of the head, and this is the nose, and this is the back of his skull. And you can see it here really growing around the eyeball. This was a very dangerous tumor that had not responded to interleukin-2 and other treatments. And rapidly after he started treatment with anti-PD-1, you can see that he had a very nice tumor regression, although the tumor didn't completely disappear on the CT scan. But when we biopsied after the nivolumab treatment, we could never find any live tumor cells. What we found here was scar tissue and infiltrating lymphocytes. Okay, so this patient is also doing very well now, more than 3 years since he started anti-PD-1 therapy. And we've even observed patients who do well, but then their melanoma recurs. And in these patients, right now we have not worked out standard procedures for how to treat them, but in this particular patient at Hopkins, we actually treated her again with anti-PD-1, and again, this patient responded to therapy. And so this now brings up the issue of what is the best way to use anti-PD-1 drugs or other checkpoint blocking drugs long term, and maybe patients should be on some kind of a intermittent maintenance dosing, or maybe they should go off drug completely, and if their tumor recurs, then they can go back on treatment. So these are the kinds of questions now that need to be addressed in new clinical trials. But with all of this activity, we have seen from early phase studies very encouraging news in terms of the overall survival of patients with melanoma who had not responded to other treatments, but who did respond to anti-PD-1 therapy. And this is showing that their average survival in this study that we've reported in several different venues with nivolumab was about 17 months, which is very encouraging, we think. And now, with longer-term follow-up, it looks as if these survival curves may be leveling off at about the 40% survival rate, because we just recently saw some 3-year data. And as you see, we're seeing similarly encouraging results in patients with lung cancer and kidney cancer. Now, I've mentioned nivolumab, but actually there are several different drugs in the clinic to block either PD-1 or PD-L1, and I'm showing some of them here. There's the Merck drug that was recently approved, Keytruda. These are 2 different anti-PD-L1 drugs, so this is blocking PD-L1 on the tumor cells. The good news is that all of these drugs have clinical activity, and so these 4 are the ones that have been in the clinic the longest and that we have the most experience, but you can see that all 4 of them are inducing a pretty significant percentage of tumor regressions in melanoma, as well as lung cancer and kidney cancer. And then recently at the ASCO meeting in June, we saw new evidence for activity of these drugs as a group in bladder cancer, in head and neck cancer, and also in ovarian cancer. And so now the profile of activity of these drugs is expanding, and we don't yet know what the limitations are in terms of different tumor types that might respond. And yet we still have a ways to go, because we need to address the patients who have not responded and try to bring more effective treatments to those patients. And so discovering biomarkers, which now takes us back into the laboratory, may allow us to select the patients most likely to respond, and it might also help us understand why others are not responding. One thing we found, for instance, in this melanoma patient treated with anti-PD-1 is that as her tumors were going away, and this is an enlarged lymph node under the arm that is a melanoma metastasis, lymphocytes came into these tumors, and these are CD8 positive, what we call killer cells. So they weren't there before we started the treatment, but they were there during treatment, and as this tumor is getting smaller and smaller, those lymphocytes are still there. So this is one kind of marker that we can look at to understand what's going on. Another one, as you heard about this morning from Dr. Atkins, is expression of PD-L1 on tumor cells, which we're seeing here in this melanoma sample next to a sheet of infiltrating immune cells. And this is a marker that is of interest to many of us right now. But again, Dr. Atkins showed you some of the limitations of using this marker, and this is something that we need to improve in the laboratory and then bring it back to the clinic. So I'll end with what we see as the future for this therapy, which is developing combination therapies that will override tumor resistance. These need to be rationally based on laboratory evidence, and there are many different varieties, including combinations of PD-1 blockade with the vaccines and the ACT that I mentioned earlier, and with other immune modulating antibodies. And I think that Dr. Walchuk is going to address all of these issues in his talk, so I'll end with acknowledgments to the team that works with us at Johns Hopkins, the other clinical trial centers that we collaborate with, and sponsors of our research. Thanks for your attention.